أرحب بكم جميعا الحلقة الثالثة من هذا الويبنار. سعدني حضوركم ويسعدني مشاركتكم معنا. معنا ضيفة عزيزة علينا اليوم، هي الدكتورة فومي أباري، دكتورة من المملكة المتحدة. من سن صغيرة إسهاماتها ما شاء الله تبارك الله كثيرة ومشاركاتها عديدة. سعيدين نحن جدا بهذه الفرصة أن نلتقي بها، وكالعادة لأنه ضيفنا يتحدث اللغة الإنجليزية سيكون حديثنا مع الضيف اليوم باللغة الإنجليزية، والأسئلة ستكون باللغة الإنجليزية. Without further ado, Fumi,
yeah.
It is lovely to have you here. Do you want to give us a few words about yourself before you allow us to listen to your presentation?
Yeah, no problem. So, hello everybody. Assalamu alaikum. Good afternoon. My name is Funmi Abari. So now, for the last 48 hours, I've actually now become Dr. Funmi Abari. So
Congratulations.
Thank you very much.
On my behalf, I'm the 17 here so far.
Thank you. So I have officially finished medical school. So a little bit about my background beyond my identity as a doctor, I guess. So I studied chemistry as my first degree. So I graduated in 2015 in chemistry. And over the last, I would say, 12 years, so that gives, I can show my age, I'm 26. So over the last sort of 10 to 12 years, I've spent a lot of time working within the community. So I'm from North London. And whilst I was growing up, I always wanted to be a doctor. I always wanted to sort of serve people. And of course, you can't do that when you're 16 and without a medical degree. So instead, you do everything else that you can. So I got involved with UK Youth Parliament. I made a public speech in the House of Commons, which actually was recorded as history, as the first non-elected MP to make a speech in the House of Commons. It was then that everything sort of began, because national papers then predicted that I would be the first Black Muslim female Prime Minister in the UK. So we'll see. I know that position is still there, so we'll see what happens. But
well, I know who I'll be voting for.
So along the journey, I've invested in trying to seek ways to effectively be as useful as I can be in my community. And so I set up 2 social enterprises. One is called the Empower Us Project, and that seeks to build resilient communities. And another is called the Race Against Medicine, and that's about encouraging people from minority ethnic groups, or as I like to call global, majority global ethnic groups, into medicine, because there are some inequalities and variances there. So I am an avid reader. I am very excited to enter the world of work and start working as a doctor. And more so, sort of the dream is to be a global leader in health, advocating for vulnerable communities and specifically for women and children.
That is very inspirational. I have one important question on the heel of that.
Yes,
you're from the north of London.
I am from the north of London.
What football team do you support?
Oh my God. So
don't hesitate.
I know that this is going to be recorded.
Yeah, it is. It's restricted in Saudi Arabia, so we promise you it will not go out. Your reputation will not be tarnished.
Will it not? Okay, that's good to know. No, so to be honest with you, I'm not really an avid football fan. So
that is you are a good politician, I can say. So well done. All right, Fumi. I would like just to point out that Fumi is a friend of a mutual friend with Aisha, Dr. Aisha Ghani, who was supposed to be with us today, but she's down with the coronavirus. We both wish her very well. We send her wishes. She will be with us in a future webinar, hopefully very soon. We know she's commencing her duties as a doctor now. She's been called to serve, and hopefully this big pandemic will, this big ride will end with fruitful events. Fumi, your presentation, if you want to start.
Okay. So I'll begin by, can you see my slides?
Yes, we can.
Oh, perfect. And is it on the National Health Service right now?
It is.
Okay, brilliant. So let me enlarge this. Okay, so I'll begin by just sharing a disclaimer effectively. So as a newly qualified doctor, my knowledge on infectious diseases of this scale will be limited to effectively what I have read and accompanied by what I've studied. So when we come to the question and answer session, and we have that opportunity to sort of, you know, discuss certain like questions that the students have and the guests have today, I just hope everybody can appreciate that I'm not an infectious disease specialist, so to speak, but I hope that the information that I share is useful and encourages everyone to, I guess, do further research. So I'll begin by explaining what our health service looks like here in the UK. So this is an extract really from some government documentation in 1948. So the NHS service was founded on the 5th of July 1948, so this is 71 years ago. And it existed to ensure, so you can see the information there at the bottom. So when it was founded, the idea was to ensure that everybody had access to healthcare based on their clinical need and not based on how much money they had. So this was a dream founded by the British people to ensure that everybody had access to good health, had access to information about their good health, and also had access to treatment. And it still stands today. So it's quite a phenomenal institution. And currently, there are 1.4 million employees. It's actually one of the largest employees in the world, and has an annual budget of 134 billion British pounds. So it's a very expensive service.
Outstanding, the amount of money.
Yeah, it most definitely is. But as outstanding as it is and as brilliant as it is, there are of course some issues and some challenges that we face with our health service. So just sort of in a nutshell, there have been reports which have stated that the NHS is chronically underfunded despite the 134 billion British pounds. So it's been reported as chronically underfunded. However, it has also been reported as being absolutely great value for money. So, and to appreciate what the NHS stands for, first and foremost, so that is to ensure that everyone has access to adequate, good quality healthcare. And then to appreciate the challenge of ensuring that that can be provided for everybody. And then to appreciate that at times it can be monopolized by political parties. So when we're voting for, who will be in power, there is always, very specific talks about what party is going to do what for the NHS and who is going to revolutionize it to ensure that it can continue to be what it always stood for. Sorry, this is just a tickle in my throat. I don't think this is anything indicative of COVID, just as a disclaimer.
Please be sure.
Yes.
However, it will be good for viewing, so if you want to cough a little bit more.
We'll see when we come on to talk about symptoms. So that's what the NHS is, okay? Right, so going on to talk about now the coronavirus, so COVID-19. I will share with you some key specifics about it, and then also I wanted to share with you what it is that, I guess as a junior doctor, what our fears are, what our hopes are, what the concerns are of, I can appreciate the majority of the British public, and also just things that people haven't really been speaking about, but are key discussions that are happening in homes, over Zoom, over FaceTime, etc. Okay, so these are current figures of the spread of the infection. So worldwide, there have been 1,118,921 confirmed cases of COVID-19. So this is the number of people who have been diagnosed with the infection, okay? And there have been just 250,000 people who have recovered from this infection, and from this 58,000 or close to 59,000 now deaths worldwide which have been reported. So the UK's numbers have been posted here. So all of these numbers have been, they were last updated about 30 minutes ago. So they're constantly changing, and literally if you just pop into Google COVID numbers, you'll find this on the sidebar. So currently in the UK, we have 38,000 confirmed cases. 209 people we know have recovered from the infection. And also we have a reported number of 3,605 deaths. So if you look at these numbers, you can appreciate the gravitude. You can appreciate that this is a infection which is spreading effectively like wildfire. It's spreading across the world. And also you can appreciate that this number has been increasing rapidly as the days go by. So last week, Tuesday, the number was not even in the thousands. So we can appreciate the gravitude of how these numbers are changing.
That is outstanding. Dramatic increase. Wow.
Incredible. And if you compare this to what's happening in Spain, for example, or in Italy, where I think there is a lot more media because they had extremely high numbers immediately after China, you know, before any other country, you can see how these numbers have drastically increased. You know, only last week was Italy in the numbers of 3,000. And there are some graphs also which show the trend in numbers and how the numbers are increasing, and all the countries are actually following suit in the same pattern. So how the numbers increased in China, how the numbers have increased in Italy, and how the numbers are increasing in the United Kingdom, the trends are pretty much exactly the same. And so there are epidemiologists, scientists, people who are researching this infection because it's new. In terms of, when I say it's new in the respect that the way in which it is affecting the country, in which it is affecting countries across the globe. When we speak of the infection, so COVID-19 was known about, if you like, since December 2019. So the World Health Organization did have information distributed about it since 2019. However, of course, we didn't have any numbers like this back then. And so the way it is spreading, the way it is infecting people, the symptoms it's causing, the level of mortality that it's causing is quite impressive, and it's shocking. And so much new research is coming into light right now, and a lot more work is being done to really truly understand this infection and how it spreads and how it works, and effectively what the consequences can be as a result of this infection spreading and how we can control it. So I'll explain the symptoms here. So the most common symptoms that we can find in a patient or a person presenting with COVID-19 is fever and a dry cough. And so if you think about all the other types of infections or problems that people face. So for example, people who experience hay fever or who have allergies, they will persistently have a dry cough. People who have a cold or a flu, for example, may also present with a fever and a dry cough. So it's important for us to go through the key symptoms of COVID-19, and then for us to explain what are the similarities and the differences between other less serious infections that people can present with. So you'll see here that the list also includes fatigue. So a person not being able to do their daily activities, not being able to sort of look after themselves in the way that they normally would be able to. It does actually cause people to be bedbound for a large number of days. But you can see that effectively what we would call this in sort of the medical world is that these are a series of very non-specific symptoms. So they're very, very non-specific because they can actually span so many other infections, so many other diseases, so many other problems. You will see that some patients who have COVID-19 also report having these symptoms. So having aches and pains in the body, which is very, very, very similar to flu symptoms, or people presenting with malaria, for example, or these infections which are travel-borne. You can have a runny nose, have a sore throat alongside the dry cough, shortness of breath, and also some people have reported having diarrhea. There are also new symptoms which have been reported, such as people have lost sense of smell and sense of taste. Some people who have been diagnosed and tested for the disease actually only had really, really mild symptoms. So they had a runny nose and lost their sense of smell, and that was it, and they were perfectly fine. And so if there is such a wide variety of the types of symptoms and also the severity of symptoms, it poses this really, really important question. How do you know that you've got COVID unless you've tested for it? And secondly, how on earth do we manage to control the spread of it if the symptoms are so non-specific and so vast in terms of their presentation? When we speak of shortness of breath, this means not being able to talk in full sentences without catching your breath. It means not being able to walk long distances without having to stop and pause to catch your breath. And a dry cough is where you're persistently coughing, but you're not really bringing anything up. So it's different from, you know, a typical cold cough where you tend to bring up quite a bit of sputum, or even in some case, maybe specks of blood because you're coughing that much, okay? So a dry cough in this instance with COVID is where it's completely dry, you're not bringing anything up, and to some extent it's quite painful for some people. So I want to share with you how we can appreciate the similarities between COVID-19 and influenza. And the reason why I think it's so important for us to speak about this is because 2 weeks ago, before the UK, before the British government took specific measures to control the spread of the disease, before the NHS became incredibly understaffed, and I'll explain the dire situation that we're in at the moment. Before all of this was just 2 weeks ago, I would say the majority of the British public thought and believed and were convinced that COVID-19 was just like the flu. We were convinced that the disease was just a bad flu that really only affected people who were quite elderly and had pre-existing health conditions. And this might be the rhetoric that you're familiar with, possibly in the media or even on Instagram and social media as well. But this is not the case, and this is not true, and it was very dangerous information. Yes, the symptoms are incredibly similar, and this is because of the organs and the parts of the body that the infection attacks. So we call this an upper respiratory disease, or even just a respiratory disease. And so it affects the bronchus, which is the windpipe, and it also affects the lungs. And both influenza and COVID-19 affect those regions. And so you will, of course, present with similar symptoms. But to reduce the magnitude of COVID-19 and to report that it is just like influenza is incredibly dangerous. And it is not just like influenza, okay? And I'll explain to you how it is very different. So we know that it's similar because of the symptoms and the presentation, but also we can appreciate that it's similar based on the transmission. And so this information that I've got here is taken from the World Health Organization website, and this was last updated in the beginning of March. Now, please appreciate that everything that I'm mentioning now can actually become out of date within the next few days, because every day, every hour, we're learning so much more about the disease, about the infection, and about how it spreads, okay? So at present, we can appreciate that both COVID-19 and influenza are transmitted by contact, by droplets, and by fomites. And what we mean by this is, if somebody sneezes, and they have influenza or they have COVID, and other people are present and pretty much within a 2-meter radius, they can become infected with the disease. Okay. And so because the symptoms are similar and because the transmission is similar, that is why I think there was a lot of, I would call it propaganda, explaining that the two diseases are very similar and people shouldn't worry too much. That is not true. And this is because the differences are actually quite stark. So the speed of transmission, so that is how quickly a person can become infected from another infected person, we can understand that actually the speed of influenza in terms of person-to-person infection initially was reported that it was faster than COVID-19. So you might be thinking, oh, okay, so maybe influenza is potentially a bit more dangerous than COVID-19. That's not what it states. In fact, if the disease can spread very quickly, it's actually, to some extent, easier to appreciate. It's easier to understand how well it can spread and also how well we can control it. Now, with COVID-19 having a longer incubation period, so this means that the disease remains in a person for a long period of time and then they can become infective. It means that you can have people walking around who have no symptoms or very mild symptoms and actually be infecting people before they even have a chance to know that they need to actually put themselves in isolation. And that is incredibly dangerous and actually quite scary. And that's why so much more information is needed on COVID-19. The other key difference is the reproductive number. And so, again, we don't have all the information on this. We don't completely understand it. But what we can appreciate is that the number of people who can become infected from one person with COVID virus is actually higher than if a person had influenza. So if you imagine you had a person with COVID-19 in a room full of 10 people and a person with influenza in a room full of 10 people as well, you can appreciate that you would have about 2 or 2.5 people being infected with COVID-19 in that room.
Can I ask on that point, Fummi?
Yes.
Is that changing as well?
It's
our understanding
changing,
of the spread.
changing.
So it might go up or down.
Exactly, it might go up or down, but the most recent information that we have on that is that bottom line is the COVID-19 virus actually causes, it's more infective than influenza.
Okay.
Now, another thing is you will appreciate that children are very snotty and they carry infections left, right, and center. Okay, so if anybody works in a school with young children or has young children, you're probably constantly wiping noses, or even yourself, you constantly got the sniffles. And this is because infections like influenza affect children a lot more, okay, than the rest of the general public, and they spread influenza and they spread flu-like viruses a lot more easier than adults do. Now, this is
from an immunological point of view, again, Fummi, do we know why that is? Because it's been presented so many times by different speakers, and everybody, from an immune background, we still don't know why. What's your guess? Because everybody's really guessing at this stage why children are more prone to influenza.
Well, in truth, I don't know. I can't. I'm not.
It's not known, by the way. It's so I'm not imagining there is an answer. I'm just trying to think from your understanding in medicine.
My understanding in medicine. Well, I guess because if you think about how a virus actually can infect a person, so a virus is different from a bacteria in that in order for it to cause infection, it needs to take host of a particular cell, right?
Intracellular infection.
Yes, intracellular infection. And so just, based on the behaviors of children, their contact is a lot more higher. You know, the level of contact, the extent to which they have contact with one another or contact with other humans is a lot higher than adults. Also, their level of cleanliness is, of course, a lot lower than I would say than the adult population. And so, but then again, that doesn't really differ. That doesn't, you know, my understanding of how, I guess, the infection can be spread with children, that doesn't differ with any particular virus. That would hold true for both COVID and influenza.
At this early stage, from the ages of, let's say, 0, the day of birth, until 4 or 8, there's the immune archiving still going on. So any virus is new to a child or to a small kid or an infant. So they are still building up that archive that will help them future infections, where they don't they don't get more snotty because they've got their memory cells to deal with it. Hence why you've got a very sick period for young children. And then between 6 and 10 or 15, they're quite, you know, touch wood, they're quite healthy.
Yeah.
That's what we think, really. It's just a hypothesis that needs a lot of proving. But as you know, human trials and human tests, especially on children, are very, very hard to do. So, sorry, you were saying about I'll let you go back to your points, because
that's fine.
It's just interesting to me to ask.
Yeah. So and so with COVID-19, it doesn't actually affect children in the same way that influenza does. So in fact, it's sort of spun on its head. And in fact, what you have is greatest infectivity or the greatest severity of the infection in the elderly population and with people who have pre-existing medical conditions. And this is something that we've heard in the news and we've seen. And actually, I think at the beginning, in my personal opinion, I think it was a driver to try and encourage people to not be scared of the disease. And personally, I thought that was, in itself, it was scaremongering, because there are many people with pre-existing medical health conditions. This includes people who have asthma, which is actually considered as quite a common, easy to manage, in most cases, respiratory disease. And being pregnant to some extent is also a medical situation, and so these women as well are at risk. And the elderly population are not people, for example, to just appreciate as a small number or as a small micro population. That's, in most cases and in most societies, they actually make up the majority of the population. We have an aging population across the Western world. And so this narrative that, you know, was continuously played out, that, it just affects elderly people and it just affects people who have pre-existing conditions, in my opinion, was a massive cop-out by anyone that mentioned that as a way to reduce the scare factor for people. Because if anything, it just increased the scare factor for all the other people who fell into those categories. And it didn't allow people to recognize that actually the fact that it affects vulnerable people with vulnerable health situations, that should be more of a motivator for us to have wanted to control the spread of the disease. And I didn't see that, and I've only seen that now, where, you know, the media and the narrative and the information and all the infographics and all of that's coming out into the televisions, you know, online. Only now is there talks of, you know, let's take these safety measures to protect people who are vulnerable, and that was never the narrative, you know, at the beginning. Is that what it's been like in the Arab world? Or?
So in Saudi, it's been quite an interesting experience. I think the government took the threat very seriously, because of the nature of the religious tourism we have. So it stopped attendance in the Holy Mosque and grand events, and it was very important for the government to restrict the spread, to hopefully make time for the religious month of Ramadan and people to come and attend.
Just to continue with looking at some of the differences, and so So again, so just to reiterate, I think what information is out there. So COVID-19, the extent, so the percentage of people who actually end up with the critical and severe type of the infection is a lot higher than with influenza. Now, I'll be very, very honest with you, from a medical perspective, when I first got the information, so this was, I would say, literally 2 weeks ago, 2.5 weeks ago, and we were, being told that how COVID-19 infects people, the mild case of the disease and then the very severe case of the disease. For me, I thought, wow, this does look like influenza. So I've treated patients who have influenza in hospital and who end up with complications, okay? But they always did have, quite severe underlying health conditions. But when you look at the numbers, it's crazy. And if you look at the numbers, so people have quoted, for example, oh, you're more likely to die from a heart attack than you are from COVID. But you have to look at, you have to ensure that the populations that are being studied are the same. Of course, you've got to keep it consistent. And if you appreciate the entire population of the UK, yes, that entire population is at a greater risk of having a heart attack, but that's because we are at greater risk of cardiovascular disease, because we're at greater risk of obesity, because we're at a greater risk, we smoke. I don't smoke, but I mean, the general population, et cetera, et cetera, et cetera. And so when you would just appreciate that 5 out of 100 people who contract COVID-19, so that's 5%. So 1 in 20 people who contract the disease have a risk of actually requiring a ventilator. So
is that regardless to the age?
So I was trying to figure out. I was trying to go into a bit more depth with these data, but they actually didn't provide any references on the WHO website. But they are consistent figures. So everywhere that you see in other literature, you will find these figures. But I appreciate that the number of people that do contract the infection, the ones that actually do present to hospital are, of course, the ones who are already within that severe bubble. So they already have the severe infection, the fact that they require medical attention.
So numbers out of Italy, for example, say that 20% of the mortality rate, the case mortality rate, are for people under the age of 40. So obviously there is a breakdown of you've got 1 in 5 go into critical condition, then from that one, you have 20% who are unfortunately dying. We don't have enough data about the underlying condition within young people, but it's definitely been a shift in our understanding, because in the seminar or the webinar yesterday, we had a very interesting talk with Abari, an epidemiologist, who covered the topic of the spread of disease within communities and countries. And one thing that came out of China was the first few cases that was referenced in the paper. The first few cases were not for the elderly, but between the age of 18 and 49. They were the first cases that came into the hospital, and they had the larger number of reported ICU progressions. So, as you were saying, going back to your point, I think there's definitely a shift in what we understand.
Yes, definitely, and it's constantly changing. And I think what is happening is, I think a lot of people have resorted to seeking their own information, because you've got different news outlets which are not. I don't know what it's like in Saudi, but in the UK, there are specific news outlets which will report specific things, and they are omitting, I would say, in my opinion, bits of information which are really necessary to draw up the whole picture. So appreciating that younger people are being infected and we still don't understand why they are developing, the severe form of the disease, for example, is honest, transparent information that I think a large majority of the population are not receiving. So what's happening in the UK is, and I think across the world, is people are being encouraged to distance themselves from each other. So we call this social distancing. And there are a few key terms which are being utilised. So we've got social distancing, we've got self-isolation as well, and we've also got lockdown. So are these terms that have been used in Saudi as well, or?
Yes. I mean, that the image you just showed us now is quite common. I've seen it on many billboards, on many advertising stands. So yes, I would agree. Yeah.
Okay, so that's fine. So we can just appreciate that everybody is being asked to distance themselves from people and being asked to take necessary measures to ensure that their hygiene is basically top notch to reduce the spread of the disease. Now there's further information on how we can do this. So sort of when you're in the home, and then also when you are out and about. So you've probably seen these images, and it's basically about staying at home. Now, to self-isolate is, I think, the thing that people in the UK have been had struggled with initially before we had the governmental imposed lockdown. So this image here, I don't know if you've seen it before, but it was a really, really good like sort of depiction of what you need to do if you do become sick. So at this point, and still today, people in their homes are not being tested. So there are some kits that are available that you can buy from like Harley Street, which is like the nice private health centres, and they range from about £100 to £200. And the specificity and the and how selective these tests are is debatable. You know, you've got some scientists, you've got doctors saying these tests that you can get sort of online are not adequate. But then at the same time, people want to know how unwell they are because they have things to do. They need to go to work in some cases. So if a person gets sick, they're asked to self-isolate for 7 days. So anybody else in that household will have to also isolate for a number of days as well. And so in total, it's you're either isolating for 7 days or you're isolating for 14 days. So 14 days for you and your family, if there is a person in your house which is self-isolating and has is presenting with the specific symptoms of COVID. And you can think about this and appreciate that, yes, you're being told to do this, and self-isolation effectively means do not leave the house. You can't. You can't leave the house for a walk, you can't leave the house to go to the shop, you can't leave the house to go and pick up your food delivery. You can't do it, you need to stay at home. And for the people who are sort of young bachelors or young bachelorettes and they live alone, how are you supported? It's impossible. You effectively, if you're well enough with the symptoms to go to the shop and buy the food that you need, for example, and you don't have anybody else that can do that for you, effectively you have to leave at the end of the day to survive almost. And so before the lockdown, not only were people not self-isolating and were only not people not distancing from other people, but there was governmental instructions and advice, but there wasn't the support to go with it. And that's the problem that a lot of people working in healthcare could witness, and we saw. So for example, your elderly population who were self-isolating without any symptoms, but simply because they were high risk, they live alone. They would normally have carers, but their carers that would come maybe twice a day to help them with food and such can't come anymore because they're unwell, for example, or the staffing numbers have gone down. What measures were put in place to support these vulnerable people, with the advice that the government was given in order to slow down the spread? And that was when communities really then had to take charge of things and start sort of resolving the problems that effectively the government then did cause with the advice. Now the advice was right, of course, but you can't climb a broken ladder, and within that ladder you have rungs, and within those rungs there are people who can't necessarily abide by these new instructions or this advice because their lives don't allow them to. And so it was quite in truth, it was quite upsetting to hear stories and hear about people on the news or even through social media who were really struggling to keep themselves safe, struggling to ensure that other people were safe because they didn't have the measures to, number one, either stay away from work because, you know, they were maybe paid on a weekly basis or their income didn't allow them to not go to work. So there were many problems at the beginning of when, you know, this advice was introduced. And finally, now we are in lockdown. So what this means is you have to stay at home. Nobody is out. I wish I could just flip my screen and show you what's happening outside the window because nothing is happening. People are only allowed to leave to exercise once a day, to go shopping for food and medical needs, and the advice is to go once a week. And also they only travel to work if absolutely necessary. Now, people are not allowed to have public gatherings. The day that this was imposed, weddings were shut down by police. You had, you know, celebrations that were in people's houses that were shut down by police. People were reporting, you know, where there were communal gatherings, they were all being shut down. And so, and people were also being fined. So I know that the fine can be anything from about £30 to about £600. And so this is incredible.
Very kind fines, I have to say. Our fines are substantially bigger.
Wow, what are the fines that you're?
Well, I mean, we'll be addressing this even more, hopefully, with the participation of some of my friends and my colleagues. But the fines have come up to £2,000 if you're caught out of curfew. And looking at the effects of it, it's understandable, to be honest. But we'll talk more about the support people get who are in lockdown, who are under curfew, under social distancing. That's something I will love to discuss with you more.
Definitely. I actually had a friend, so he works, so the city that I'm in at the moment is Leeds, and he works in a neighbouring city. And because he's working with the civil service, he still had to go into work for, you know, the first few days of lockdown. And so he was stopped at the station by a police officer and was, you know, and was questioned. And he said it was a bit comical initially because he wasn't wearing, you know, his normal, you know, work attire because obviously he was the only one in the office. And so the police officer didn't really believe him, and it was a bit funny. He did share the story, but you know, in some cases that's happening, and in other cases there are people who couldn't even get to work because, so for example, in London, the tube is still running, but in specific locations where it's normally very busy, you can't get on the train from those locations, and so people are having to, you know, organize taxis and such, and especially if they're on a low income, it just further aggravates their own personal situation. So I was going to talk through how a ventilator works. Do you want me to do that, or?
I think I wanted to ask about that actually. So, actually, can that slide stay there? We can see you, and that slide can stay there because it was one of the ways I was going to go leading to my questions. Because, Fummi, first of all, thank you for the very informative few slides. You really covered a lot of points I was going to ask. One of the first things that I noticed the recovery numbers in the first slide were very low in comparison to the total number of infected people. Why is that?
So I was trying to find the specific definition of what it means to recover from COVID in this context, and because the numbers, you know, it's not matching up. But what I have been able to find, so I'm still searching this actually, but what I have been able to find, and I'll need to authenticate this, is that the recovered numbers reports the number of people who have sought medical attention as a result of, you know, being infected with COVID, of course diagnosed with COVID subsequently, and then left hospital and returned home.
So that gives you that puts a lot of question marks on the actual stats then.
Most definitely it does.
So yeah, who do we consider recovered? Who do we consider sick? Especially that we know that the vast majority are asymptomatic. The papers out of China and now out of Germany are ranging it from 50% to 80%. So if that's an average of 60%, that is still a huge number of people carrying the disease with no clear symptoms.
honestly, it's just very scary. It's very, very scary. And I'll share with you as we move forward about, with all of this information, with it being so uncertain, the NHS have plans to recruit doctors who have just qualified to start working now, and also to recruit some medical students as well in their like penultimate years.
Drastic measures.
Exactly, and if you think about this, you know, we'll talk about this in a lot more depth as we go. But if everybody knows, and if the current data that we have, you know, the scientific data that we have now informs us that it is effectively not possible to track everybody that has the disease, you know, just because they might not present with symptoms, and the tests that we have currently, we're not rolling them out fast enough. And so you could feel completely fine working on a ward with patients who are also COVID-free, but with other diseases. Of course, the hospital exists to treat everybody, not just COVID patients. And you could be infecting these people whilst you think you are doing quite heroic work. So
then the motto now that we keep hearing,
yes,
in the States, in Europe, test, 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 test.
Mm-hmm.
Where does that, or where do you find that, and how can you rank that in importance now?
So initially, whilst I was still in the hospital, so doing my placements and just sort of wrapping up my medical degree, if you like, so in the last few stages, I didn't even know that medical staff were not being tested. At this point, it wasn't even sort of in the headlines that they weren't being tested. You expected them to be tested, right? So as the weeks went by, so this was probably, you know, the end of February, I think, beginning of March. I just expected staff to be tested. You know, I was informed by one of the consultants actually on the ward. You know, he came in quite frantically and he said, "Look, I've just come from a COVID meeting. You know, we're being told that we need to, you know, prepare 1 bed per ward for a COVID patient." He was livid. He said, every single bed in this ward every single bed in this hospital is going to end up being a COVID bed unless we have the testing. And at this point I thought, what? That no one's being tested? What? You know? And at the same time, you had medical staff presenting with mild symptoms or maybe no symptoms, and you had patients who, you know, you suspected were COVID. And at this point, there wasn't even like a specific COVID testing center in the hospital. That happened quite late into March, actually. I'd say maybe the second week. But at the same time, all of this was happening in our health service. You also had celebrities being tested, British celebrities being tested. And then a couple of weeks down the line, we had our Prime Minister being tested, you know, within 24 hours.
That's great. Well, and his Royal Highness.
Yes, exactly. And at this point, things become really unclear because you identify that, of course, it's such a priority for these individuals to be tested, but not the people on the front line. And then there's actually quite some conflicting articles which have come out actually stating that at this point now it's too late. We're too late in the game. And I don't think of course it's beneficial for staff to know if they are possibly infecting people, but then they have to follow guidelines and then they would have to isolate.
Why is that though, Fummi? Is it because of the quality of the tests are not there yet, that they can't flood the hospitals with? Or do you think there's actually selectivity, which is unfortunate in both cases?
I'm not, if I'm really honest, I'm not so sure. So I know some hospitals are testing patients who present with particular symptoms. There's like a drive-through system and they're testing them in that way. But in terms of staff being tested, I think some staff are resorting to doing it privately, you know, and purchasing these £100-200 kits.
Just PCR kits and just doing it in their own, in the lab.
Yeah. I think I definitely know a friend of mine. Her brother is a doctor, and he's bought a couple of kits. He's even said, "Oh, I'll send you one if you want." I said, you know, I'll be honest. When I start working, so possibly in a few weeks, then you know I might like to do it then. But I believe I'm symptom free at the moment. But you have to appreciate this. Once a doctor or a nurse or a medical professional, anyone who's working in the healthcare system, If they are identified and diagnosed with COVID, they have to isolate. So that's going to bring our workforce even further down. And there are many departments which are incredibly stretched. And that's why our health secretary wants to recruit like 5,000 medical students into the workforce, all the qualifying doctors who would normally start work in August, they want them to start working now. We've recruited retired doctors, retired nurses, etc. So that number is just going to continuously be reduced as we go with the testing. But at the same time, we'll be reducing numbers in the workforce, but we'll be ensuring that our patients are best protected, because the people who are looking after them can be free of infection. But then, how many times do you test? If you test me on Monday, I can go into work on Tuesday and contract the disease.
That's exactly what I was going to point out. So you might not show any positive RNA, viral RNA in the swab on a Monday, but on Wednesday you might have enough of the viral load in your oropharyngeal or the back of your throat that you can actually show a positive result. But it's puzzling, really. It's puzzling. Should we see what Professor Adil has to say?
Yes, please. Yes.
Can you hear me, Professor Adil?
Hello, hi. Yes, I can hear you loud and clear. Thank you very much for giving me the opportunity.
No, please.
Actually, it's a very interesting discussion. And I think that the world, especially WHO, and they have huge responsibility on, how to share data and how to come up with viable solutions that can be adopted by majority, if not all. Every country has got their own socio-economics, and I'm going to specifically focus on Saudi Arabia because there might be some advantages that we have over here and some disadvantages. So far, the country is doing, the government is doing absolutely, I think they've done a fantastic job in containing the disease at a very high cost. But the thing is that, of course, this is it's short term, and the long term strategy, everybody is still questioning about that. We have been in partial lockdown, all the major cities. I think the big advantage that we have is that our population it's not too much. It's still between, if I'm not wrong, 28, 30 million people. So already the cities have been under partial lockdown. And then they've identified over the past 2 weeks that, 2 or 3 cities have higher rate still being reported. So these cases are being reported like Funmi Abari mentioned, that once the symptoms have developed, only then they report, and it's already too late at that time. So I think, we still can go with the South Korean model, where now we have the zones. The zones have been identified where the high-risk people are still, because one of the disadvantages what we have is that people over here, they love to socialize in terms of, even, and it's a bit uncivilized behavior that, they have clear instructions. The government is, doing all their best to let everybody know that how critical it is to isolate yourself and go into self, lockdown. But still, the nights are spent, chilling around with the cousins, with everybody else. And then we have other factors that come into the house, like drivers, like the maids, who might go and intermingle in other places and then come and bring infection, in the house. In addition to, the socializing that's still going on. So these are these have, but however, having said that, even these zones have been identified, and cities like Mecca, Medina, there are zones, there are districts that are now under complete lockdown. So I think that this is the ideal time that those high-risk zones can be tested using the RT-PCR, the RNA-based kit, which Abbott has recently introduced. Of course, it's a huge challenge to bring those kits and everything, immediately available, because those companies have to now supply in their own countries first. But having said that, probably, privately, people who can afford, or organizations, or through the government, because the government is already putting a lot of money to support the economic, you can say, the challenge that we are facing, or the whole world is facing. So they are already. So I think it's time that those kits should be brought in at any cost, and those high-risk zones can be tested. With mobile units being brought into the districts, and since we are all on an electronic platform called IBSHIR over here, so we can all be asked to go and test, and the results can appear on IBSHIR program, and everybody can, the government can know about that, who got tested and who did not, and they can, and that way, probably within the next 2 weeks or 3 weeks, I think that the cases will eventually, they will filter them down, and they will be, However, this is the long-term strategy. It's a virus at the end of the day, is highly contagious, like you mentioned. And I think that eventually there will be some sort of herd immunity that will be going towards. I might be wrong in saying that, but
Professor Chaudhary, I have a question on the
yes.
heel of what you were saying. You were saying about the long-term strategy and hopefully the appearance of herd immunity. Can I just ask about the probability in your mind and your closeness to the clinical field and the diagnostic field, hospitals and whatnot here in Saudi? How prepared are we for the increase in numbers?
Look, I would like to make one thing very clear, that I am not a virologist, and I am not someone who is working in an active health center all the time. So for me to give you a statement on your question will be just, I don't think it will be accurate. However, having said that, we have hotels that have been allocated for isolation. We have, I myself went for COVID-19 test 3 days ago, and I got it done in a very highly specialized lab, which is part of a university over here in Jeddah. And they are doing this testing at least as a screening, and they are receiving samples from the Ministry of Health as well as from other hospitals in Jeddah.
Did you do a real-time PCR, Professor?
Yeah, I did the real-time PCR, but not the 5 minutes one. It was the one that was, I got the results at night after about 12 hours.
6 hours, 12 hours.
Yeah, because they have, yeah, exactly. So, so they're very, it's basically, I'm part of that lab, it's called ROIA labs. And the facility, they have the level 3 for infectious disease sample handling also facility over there. And it's very well equipped. So in the hospitals are extremely well equipped. The doctors, they are very well informed, because both of my brothers, one of them is a cardiologist and the other one. But I mean, regardless of that, all their colleagues are very well informed. However, since it is a highly contagious virus, it cannot be contained 100%. And it takes only one person, like, that number 31 in South Korea. It takes only one person to contaminate, at least, just trigger a cycle that becomes very difficult to control, because again, due to the incubation period. So even in health centers, there has been rather very little kind of situation where people have been found with COVID-19, and those centers have been shut down. I mean, we have the example of, 1 or 2 hospitals in Medina. One hospital is completely shut down.
That brings me to the question, Professor Adil. Yeah. That point is very important, and that allows me to ask Fumi a further question. Thank you, Professor Adil. Thank you for the points.
Thank you very much. Thanks for your time.
Thank you. Thank you very much. I was going to ask you, Fumi, with the lack of testing, with between 2 brackets what you were suggesting is selectivity in terms of testing to the people with power and money, let's say, which is unfortunate. Can that put hospitals and medical centers at risk of being hubs for the disease, from your understanding?
I mean, they're already hubs for the disease, in truth. The majority of people who every hospital. I'm sorry, I'm not so sure if I understand.
So if this highly contagious disease is being transmitted by droplets, and we don't have our medical staff being tested enough, and we know the high rate of asymptomatic patients, will that mean that we're curing a disease while, unfortunately, the warriors or the soldiers that are trying to cure the disease might unwillingly be reinfecting people?
Yes.
Yes.
Yeah, I think so. Yeah. I think that's the concern that a lot of people have. I haven't been in a hospital for the last 2 weeks, so that's honest truth. But as I was leaving, and as I was leaving hospital, and from the information that my colleagues who are doctors or friends even who are telling me, things initially were very chaotic. And I think at the moment it depends which hospital. Some hospitals have the capacity and have the ability to really manage the situation a lot better than others, and that's the truth. And either that's because of money or manpower or location, or because of the influx of the number of COVID patients that they're receiving. It's quite varied. But I think what I understood from the situation is that a lot of information was being driven top down. So for example, from central government, there were instructions, there were new policies being curated on how hospitals should manage the situation, filtered down to NHS managers and then disseminated through staff and of course in the hospital. And for me, that never made sense. If the people on the ground are dealing with the situation, they should be the ones delivering the instructions on how it should best be managed. And so the most vivid memory I have is in a particular hospital near me, where I was doing my placement in. Actually, you had the emergency services, and you effectively had a board, and the board was what separated the people who were coming without COVID symptoms and the people who had presented with COVID symptoms.
Wow.
And that was literally how the ward was separated. And at one point you had staff entering that area, going to the other areas of the ward, simply because they needed, material and equipment for taking bloods and cannulas and doing, various skills. And the sort of the protective equipment that they had moving between wards, or makeshift wards, if you like, was an apron and gloves. And also, if we now talk about PPE, so the protective wear that healthcare staff have the right to wear, that in itself, I appreciate that there are many trusts which are sanctioning their staff for speaking out on the lack of PPE equipment. And so new ways have had to be created. So I know that there is an anonymous reporting system that doctors and nurses and other healthcare professionals can use to report the lack or the inadequacy of the equipment or that they're being given by their trust to look after patients or to even move around within the hospital. And so the situation is I don't think there is a lot of trust in how it's being managed, and specifically for the people who, the soldiers of this war. You would never send, a soldier. None of our soldiers would ever leave our country to fight or even to protect another nation without so much as the correct uniform, let alone without, warfare, let alone without, the proper medical care that they need, just in case that they become, unwell or injured. And our medical staff are not being treated in the same way. I mean, the key things are, so your doctors would normally have, so at this point now, all of the junior doctors would have swapped and moved on to like a new part of their training program. So that was halted. So for example, a doctor who was working in emergency medicine for 4 months would now be changing onto their next rotation, so maybe pediatrics or obstetrics, for example. But that was halted in the middle of March, and they were told, no, nobody is changing, everybody has to stay where they are. okay, which made sense, of course, to reduce the need for further training, etc., etc. But it's quite a dire situation, because amongst everything that's happening, this is people's career. You know, if you don't have access to, for example, pediatrics, which is your lifelong career, which you've worked so hard to, you know, to get a job in, and you're being told you can't access that job now, that personally, that's already a sacrifice that you have to make, or that is being imposed on you. Secondly, all annual leave. So if a staff member had time off work organized and arranged, all of that was cut. So you could have been working for months and months and months and have maybe a week off, or maybe 2 weeks off planned, maybe this month, like a lot of staff actually did, cancelled. You don't have the time off. Thirdly, you're still going home. So a lot of people don't have the means to live outside of their family home to reduce the risk of spreading anything to them. So there are a lot of people that live with their families, their parents, their children, their loved ones, or even friends, etc., who are now at risk as a result of you know, their individual decision and sacrifice to go to work and to support people. So there is a lot that is happening, and I really, really do empathize with I guess my colleagues, because to some extent they don't have a choice. Of course they don't have a choice because this is their work, but also because of the top-down decisions that have been made. They don't have a choice really to change how they work in order to best protect themselves. And I understand that, you know, a friend of mine actually reported that she's become quite miserable at work. It's incredibly stressful. There was a 48-hour shift that her colleague had to do on call over the weekend. You know, she mentioned that the nurses are crying all the time. And this is one particular department in a particular hospital, so I can't speak for everybody. And it doesn't speak for everybody, but it is an emotionally, I would say, depressing situation for a lot of people.
It sounds like these stress levels are unimaginable, especially that it all came at an unprecedented pace. I don't think the whole world was prepared.
Right.
Fummi, I want to ask you about, or can you take us please through what step-by-step procedures are taken for a patient who comes in? Let's say John Doe walks in and he says, I've got a dry cough, pain in my chest, I am lethargic, and I have a fever.
Okay.
Take us through what happens. How does the trained staff deal with it?
Okay. So prior to all of this, if a patient has those symptoms and they're at home and they can manage with it, the advice from the central government is that they stay at home and they self-isolate. The only time when a person should seek medical attention is when they are short of breath or when they are getting progressively unwell. And so in key things that they're unable to breathe, so they're finding it difficult to breathe, and also their symptoms are making them quite violently unwell. Otherwise, they need to stay at home and self-isolate and effectively manage the symptoms at home. Now, if a person does become incredibly unwell and then they seek medical attention, they will either call the ambulance or they'll go straight to the emergency services. So things may have changed since I was last in hospital, but what we had set up finally was it was a COVID testing center. So basically, if you had COVID symptoms and you were not managing well with it, you would go to a department, an area within the emergency services, which was a bit cornered off, and you would wait there. And then you would be seen in like a little booth outside of the hospital. So this is outside, it's sort of like in a little tent. You'll be seen outside and 2 nurses would come and see you. And they would be geared up fully with the PPE wear. And then following that, all your observations would be done. Some testing would be done. I don't know if the COVID testing was done at this point for a patient. I'm not entirely sure. My assumption is that it would have been done, but I appreciate that, you know, the availability of these tests wasn't, I don't know what it was like in the hospital that I was working at. So after that, after you've been seen by two nurses, in PPE, and all your observations are done, so they'll assess you, they'll check what your blood pressure is, they'll assess what your breathing is like, your oxygen sats, how much oxygen is getting to your body, and a general overview assessment, understand what your medical history is like, and also how your symptoms have progressed. So like a clinical history would be taken as well. And then you would be seen by a doctor in the booth as well, who would then do a final assessment of you. Based on that so that would be a senior doctor. Based on that senior doctor's assessment of you, you would then be admitted onto the COVID ward. And at that point, everything else that happens then onwards really depends on the gravity of the patient's symptoms, so how severe it is. In the cases where, so in truth, everybody that I have heard of that was admitted to hospital with COVID ended up on a ventilator.
Every person
from that I am aware of. So either the patients that my colleagues were telling me about, or through personal stories. So if family, friends, for example, if they were admitted into the hospital, they ended up on a ventilator.
And is it necessarily where they arrive in dire condition?
So the dire condition could be that they're struggling to breathe, and struggling to breathe for anybody is horrible. It's horrendous. You can't take a deep breath. You're taking very shallow breaths, and even with those shallow breaths, you're not getting enough oxygen. How
do they describe it? When you ask patients, how do you feel when you breathe? Is there a specific kind of term they use? I know
you can hear it.
So there's a short kind of whizzing.
Yes, and for patients that already have pre-existing conditions, they may not arrive at the hospital with dire conditions. They may just know that they feel unwell, know that they may have been in contact with people because they hadn't isolated for a period of time.
In an interview we've heard previously, Fummi, that the ventilator usually, when the ventilator is administered, usually patients are in a situation where they are closer to the end. Is that a fair assumption, or do you think that is? I mean, of course, I am not a medic. I'm just building up on some of the interviews we've heard with medics who are dealing, as you are and your colleagues, with this pandemic now. Is it kind of a final resort that usually?
Yeah, so it's definitely in the highest upscale of the management that we can provide for a COVID patient. So the minimum management that we can do is put them on some oxygen with an oxygen mask. So just a normal mask attached to oxygen in the wall, and then monitor them, manage their symptoms, manage their pre-existing conditions if they have any, optimize their healthcare, and constantly review them.
What's the window we have? If we have a range of windows, what's the window we have that we know once the patient passes that window, he or she has passed kind of between two brackets, danger zone, if I may call it, from a...
I'm not entirely sure. And I think in truth, because different hospitals are doing different things, I'm aware that, for example, if a patient has COVID, and they are on the ward, and their symptoms haven't improved for a number of days, either it's stagnant or it's getting worse, something can be put in place which is called a DNA CPR. So that means do not attempt resuscitation. Normally, this would be put in place. So outside of the COVID world, if you like, we have DNA CPRs in place for patients who are on end-of-life care, or for patients who are very, very frail, or for patients who are in hospital and they have a myriad of comorbidities that if their heart was to stop, jumping on the chest and doing CPR would bring no benefit. Okay, so we have DNA CPRs in place for those patients. Now, a controversial decision has been made by some trusts to implement a DNA CPR for any COVID patient that walks through the door.
When you mean any?
Any patient that gets admitted into the hospital with COVID can be, or would be discussed, rather a DNA CPR will be considered for this person. Now, the reason is not just because will they receive benefit if their heart was to stop, would they return, would circulation return to their body, and would they have good enough health to sustain life post, the resuscitation. But also, in order to jump on that patient's chest, that's the term that we use, it's not physically jumping, but in order to start the resuscitation, you need to be in full protective wear. And you need a number of people, usually you need about 7 or 8 people managing that situation of a patient whose heart has stopped. We don't have those facilities right now.
That is drastic. That is, this is the first I've heard of this, and it sounds unbelievable. So not that I want to dwell on this because I really want to hear about the ventilators, but not even taking into consideration the age or comorbidities.
So I'm not entirely sure about that, but I know that one trust in particular definitely. This was last week when, so at the middle of last week when it was in discussion, and the doctors that work in that trust were communicating with us, with colleagues, and it was in conversation, and it was very much near the end of, I would say, being implemented. Okay. Now, it doesn't mean that every patient that walks in will have with COVID will have a DNA CPR issued. But it means that it will be considered for every single COVID patient.
And that alone is very scary.
And so knowing, when is the sort of marker that indicates this is, really severe for a patient, what is the marker?
Yeah.
I think contracting the disease alone is quite scary. The fact that somebody might need medical attention can be quite scary. Mm-hmm. But we have to remember that there are many, many people who are recovering from the disease.
Yes.
There are thousands of people who are recovering. Yeah. And there are many people that, we may know of at the moment, that I know of, who are on ventilators at the moment. And we pray that they come out of this and that they improve and that their health returns.
Our prayers and everybody else. I can see it's an emotional topic for you. You've mentioned a very important piece of hardware and equipment that we've been hearing about a lot in the news, ventilators. Yeah. And you've thankfully kept that slide for us there. After you finished your giving us a brief understanding for the laymen like ourselves about the ventilator, its importance, when it's administrated, I'll then open the panel for some questions from my colleagues who would like to participate. So yes, please tell us about the ventilator.
Okay, so a ventilator is basically providing the mechanism of breathing outside of the body. So what your lungs do is your lungs enable you to oxygenate your blood, and you bring the oxygen in through breathing, of course, right? So when a person has quite severe respiratory disease, so not only COVID, but if a person has like quite severe asthma, if a person has had a cardiac arrest, their heart has stopped, blood has come back, everything is very slow, everything is dampened down, they need support for breathing. And so that's what a mechanical ventilator will do. It will effectively do the process of breathing for a patient. So we have to appreciate the extent of damage that is done to the lungs for a person to need a ventilator. So the first thing is that a person is exhausted before they get on the ventilator. Trying to breathe is hard work. And if you can't breathe, either because it's painful or because your lungs are filled with a disease effectively, or because there's now scar tissue in your lungs, which is something that the COVID virus does, everything becomes tight and difficult to move. And so you don't have the energy, firstly, and secondly, you don't have the ability to move your lungs efficiently so that your body can be oxygenated. That is a problem, okay? If your heart is beating fine, if everything else is effectively fine, but you are not ventilating your lungs, none of the oxygen is getting to your heart, into your blood, and then thus nothing can be oxygenized, and a person is at risk of death effectively. And so a person gets on the ventilator either because they have reached, or is put on the ventilator either because they have reached a dire situation that they can no longer ventilate their own lungs, or because they are at risk of reaching that point. Okay. And also for somebody to be at risk of their lungs function to become quite poor, if you're at risk of something, it means that most likely you can end up in that situation, but it also means that you might not. And so that's why a person that is put on the ventilator, it doesn't necessarily mean that they are in a very dire critical situation. Because of the demand for the ventilators, the patients that are going on the ventilator in areas where there is a higher demand for what we have present in hospitals, of course it would be it would be mainly the critically ill patients who would then be put onto a ventilator. So how it works is you've effectively got like a suction, and that's here what you can see, and this thing will move. It's like a vial that will move up and down and provide a specific level of pressure that oxygen will be flown through, and then this will be entered directly into the patient's lungs. So you can see that the mask here is not like a face mask. There's actually a tube, and what we call this is an endotracheal tube. So the tube goes directly into the patient's throat. So if anybody tries to put anything down your throat, you would gag and you wouldn't allow it to happen, okay? And so for a patient to be on a ventilator, their level of consciousness needs to be reduced. So either we can induce this medically, so we can give them like sedative, or the patient might be in that level of comatose state due to the progression of their disease. And so a patient on this ventilator will require quite a lot of monitoring. So this means that a nurse or a healthcare professional will be observing them pretty much on the hour, or even every 30 minutes, assessing their blood pressure, assessing how well their ventilation is for their lungs, assessing their heart rate, etc., etc. And what you can have on the mechanical ventilator is information about how well that ventilation is happening. And effectively what this does is it reduces it enhances effectively the patient's lung function, and it enables their body to be well oxygenated, far better than it would be if they were trying to breathe for themselves. It's scary, I think, for families who have relatives on the ventilator, because of course with a patient with COVID, and any patient at this stage, all of our patients in hospitals are no longer allowed to receive any visitors. So if a patient is on the ward, for example, maybe for cancer treatment, or because they've maybe had surgery a few weeks ago and they're still in the hospital, they are not allowed to have any visitors visiting them. So this includes children as well. So for the patients who are COVID, who do have the COVID disease, and on top of that are on the ventilator, you've got family members. The only way they can find out how their family member is doing is by calling into the hospital, or maybe even having like a video call to see how their relative is doing.
I guess seeing their relative on a ventilator will just, especially with the news, will just only break their heart, I guess. But it's a necessary machine. I mean, you've elaborated on its importance. Do you want us to take some questions? See what the people have to say?
I wanted to just share a few things. It's just two or three more slides.
Oh, there she is.
It is a dire situation, but there are some acts of quite wonderful kindness that is being sort of spread and implemented across the nation, really. So I've lost track of the days. What day is it today? Oh Lord, it's Saturday. So every Friday at 8 o'clock, or every Thursday at 8 o'clock, everybody comes out of their window or just steps outside their doors to give the NHS team a massive round of applause. I don't know if you've seen this in the media.
Yes, we've seen it. We've seen it in many countries actually. But
Yeah.
I was very happy to see it happening in Manchester, where I've studied and spent most of my life. So yes.
So it is.
I must say that clapping in Manchester was much more profound than what I saw in London.
Was it? Londoners were okay.
Of course, I'm just trying to build up the rivalry.
Yeah. But people have conflicting views about this. Of course, it feels great to know that my colleagues are being appreciated by the community. But if things are done, I think, without thought and without integrity, it then just puts a plaster on the problem. I think when everybody comes out and gives the NHS staff a massive round of applause and they're staying home, of course, these are all excellent things to do. But I want to see the outcry. I want the national public to be angry or to even be moved by how undervalued NHS staff have been for a number of years by the government, by our current government, I can say, in their decisions to make specific cuts or to reorganize budgets, decisions and infrastructure decisions that were made, which have caused some problems in our health service. And I want people to, of course, give a massive round of applause and appreciate our staff, but also appreciate that some problems that exist today and are magnified with this pandemic are a result of political decisions. And I can't wait for these discussions to be had on national platforms about how our country or how our political systems really need to value NHS staff. And not only NHS staff, all the staff that are working in the supermarkets and the groceries, the people who are still doing our bin collections and cleaning our streets, etc. These people need to be celebrated, but of course their work needs to be protected and valued. So medical students are being encouraged to volunteer and serve the NHS as well, and this is something we can maybe discuss with some of the questions. And I also wanted to pay tribute to some of the doctors who have died whilst serving our NHS, and something quite paramount, I think, definitely for the Muslim community, has been, because previously, just prior to the pandemic, there was a lot of talk and decisions being made about sort of, to an extent, almost there was some public dissatisfaction publicized for doctors who ultimately weren't white, okay, who weren't British or who weren't English, more so, shall I say. And to see that the first people who died for our country during this pandemic were ethnic Muslim doctors, subhanAllah, I think it was definitely quite an emotional a realization for many people here in the UK. And I think there have actually been a few people that have come out publicly and said that, in the previous weeks before the pandemic started, I think there are a lot of people who should be quite embarrassed and should be quite ashamed of some of the things that they have said about our brilliant doctors and nurses as well. And with this, you've got staff who are risking their lives and as a result, unfortunately, passing away after contracting the disease. This is a big scare for people who are now entering the workforce, like myself. That there are big decisions that need to be made. At the same time, you want to support people who are in need, because this is why you signed up for this job. But at the same time, you never in a million years imagined that you would have to weigh up the possibility of potentially contracting such a contagious infectious disease, and appreciate that there is a risk of death that comes with it. And finally, I wanted to end on quite a light note. This is a picture of an estate in East London, and we have some deers who have begun occupying our green spaces.
Oh, that looks lovely.
Yeah, because there are no humans around in the streets, and so there have been a few I think there have been a few moments to smile during this crazy situation that we find ourselves in.
Even before I open the panel, you've been more than gracious with your time with us, and your presentation has been more than informative. So I know it's a hard time, and I'd like to acknowledge that you've actually given us this time to shed some light on how it is being on the front line in a country where the pandemic is rapidly increasing with no clear end or no darkness coming to an end. But keep your spirits up. People like you will hopefully help us keep our faith up.
Inshallah.
Inshallah. Shall we open the panel for some questions?
Yep.
I've got my colleague and a good friend of mine, Dr. Tarfa Turki.
Hello, Dr. Tarfa.
Can you hear me, Tarfa?
Hello?
Yes, hello.
Hi, yes, can you hear me?
Yes, we can.
Yes, thanks a lot, Fummi, for a great informative presentation. First of all, I would really say that, like, really, my heart goes out to all the people in the UK, and especially the NHS family. It's really hard, I know, it's scary after everything you said. It's like so brave that you're dealing with such a pandemic, contagious disease, and it's heavily, understaffed. You are understaffed, and it's a bit scary, just imagining the situation there. So it's a bit. I wanted to comment on something that you said earlier about children's being the main drivers of influenza virus. To adults, and you were comparing that to COVID and why the transmission rate in COVID is higher. So I would expect, like, just from the fact that we know from the previous coronavirus members, the SARS-1 and MERS, they were both, they had a high survival rate on the surface, like up to 9 days on metal, glass, plastic. But if we compare it to the flu virus, which maybe usually have just around 48 hours on the surface. So this is, I think this is going to play an important factor why it was transmitting in a highly rate before, you know, the increased awareness of people of disinfecting all the surfaces and stuff. The second thing I think is something that we should take into consideration even here and maybe in the UK is that up till now, the recommendation from WHO and CDC is that the isolation period is only 14 days. But there's a lot of cases in China, and actually here we have like few cases, but still we are taking the 14 days for granted, that after the 14 days, specifically after 17 days, people have showed symptoms. The study in China included 100 children and 233 patients who had symptoms after 17 days. So that's, I think that's the scary thing that maybe we're gonna face in the future if this has been confirmed. And that's it. Thank you. Thanks a lot.
Thank you.
Thank you, Tarfa. Thank you very much. I'll take this back to another colleague of mine, Dr. Fadi Gashkari, a virologist friend of ours. Dr. Fadi, can you hear us?
Yes, I can hear you. Hi.
Hello.
Hello, how are you, Funna?
I
hope you will do well.
Thank you. Thank you very much.
Today, I just want to tell you guys this. Today, I've seen this news that the CDC has changed the recommendation from not wearing the surgical mask to use even a cloth to cover the face.
Oh, really?
Yeah, it's interesting, and it keep mounting the evidence that this virus could be airborne disease, not just air droplets. And do you think we are going to see WHO will change recommendation as well? Also, this is one point. Also, I wonder how many patients can use one mechanical ventilation. I heard that in USA they use like 4 patients can use one mechanical ventilation machine. What about UK? What is the average?
I'm not sure. The ones that I have seen, because there's many different ones, and there's many ones which have been created by different companies. But the ones that I have seen on the ICU, you know, in my experience of working, it's always one per patient. There's only one per patient. But I know that there's, for example, there are different types of ventilators. So you can have a mechanical ventilator. You can have one which can be operated. There's automated ventilators, and there's mechanical ones which can be operated by a person, you know, standing there and doing that. But of course, that's a waste of human resource. But I'm not sure. I have never seen one which can serve 4 people at the same time.
Can you hear me, sir?
Hello. Can you hear me?
Yes, I can hear you.
Hello.
Hello.
Yes, hello. Can you hear me? Siri?
Yes, of course we can. You've mentioned a few comments that I think are very valuable.
Yes. Thank you very much. Just want to say some comments about the situation. Actually, I think our problem that's internationally, when we feel ourselves start to know about SARS-CoV-2, we find ourselves are really unable to understand how this virus really react to all the world. And the problem that we still need more time to understand more and more about this virus. It is unfair to compare it to any other outbreaks previously and take it as it is. We have to be more patient to understand more about this virus. What I want to say that most of the recommendations, especially mentioned by the WHO and even the CDC, it's changed every couple of days, and it is not really a good sign, because that means it's really not understandable even up to the highest level of the health organizations. However, we have to apply the all valid recommendations to protect ourselves and our people everywhere, like social distancing, which is the most and the more valuable and valid and solid corner we have to rely on. My question to you in the UK, is there any recommendations by the NHS about using the face mask, surgical mask, or whatever barrier in public, especially if the lockdown or the curfew is not really full covering the UK? And the other point I want to ask, is there any recommendations for the healthcare workers there back in UK to use a prophylactic hydroxychloroquine with azithromycin or any other as a prophylaxis, not as a treatment?
Very good questions. Thank you very much, Al-Mundir. So 2 very good questions, Fumi.
Really good questions.
Now that we've allowed the social distancing is being pushed for.
Yes, it's a medical question. Excuse me, because I'm a physician scientist. So
always welcome. Always welcome, Mr. Al-Mundir. Always welcome, Doctor.
Thank you.
So the question is, the first one is basically, now that there are no curfews implemented in the UK, is there a recommendation to use face masks? Now, this we've seen vastly recommended in Asia, with little to no following in Middle East, Africa, the Americas, and Europe. We've seen some recommendations of it on some news outlets like the CNN and topics discussed in the BBC. But has it been recommended in the UK?
So, in terms of amongst the general public, I remember the last I heard about this. So things might have changed since, I'll be honest, since I've been out of the house. People do. So the last I had was that there was conflicting evidence as to whether it was actually useful, or so everything has to be evidence-based. Okay, so before we before instructions are given to the general public about protecting themselves. And so I think the evidence was just too conflicting as to if the general public in truth were able to use the masks in ways that would ensure that they were getting maximum benefit of it, and not just, you know, increasing their chances, in fact, of actually, you know, becoming infected. So the latest I did see, there was some material that was publicised in London, actually, I think in the Underground, about how to make sure that you were using the masks effectively. So they mentioned it has to be disposable, and they mentioned about ensuring that you wash your hands before you wear it, and then they mentioned about how many hours you should keep it on in terms of ensuring that you can breathe effectively, and then how long it can protect you for, if that makes sense, and then how to dispose of it. And I haven't seen any updates in that information. I haven't really seen a spread of that information, you know, in other parts of the UK. And so, in short, I haven't heard that the government has encouraged people to use the mask. Granted, people are using masks, people are using scarves. Personally, I have a reusable mask, which is actually used for pollution and dust as a cyclist. I'm not a cyclist, I should actually be one, but I bought that some time ago. But it does protect against, it does claim that it protects against microbes and viruses and bacteria, provided it's used properly. So I think, in short, people are covering their mouths when they go out, or doing their best to, but you might have seen images circulated of the London Underground, who are, you know, of people who are commuting to work, and you might see a carriage of maybe 20, 30 people, you know, packed together, and 2 people have a mask on. So it's quite difficult to get hold of at present. And secondly, I don't think that there is enough confounding evidence to instruct people to cover their mouths. But in terms of in the hospital, I am aware that you know, doctors are not being encouraged to wear the mask sort of across the hospital, because I think, quote unquote, it instills fear in people. But of course, in the COVID wards, so in the COVID specific wards, yes, they are using surgical masks and other you know, protective equipment around the face. But on the note of masks, I did actually read something recently about people who are hard of hearing. And for those patients, I understand that the masks have been a real barrier for their care. And so it's difficult, especially for the COVID patients who are hard of hearing. Everybody dealing with them effectively should have a mask, and those masks are not transparent. And so how do you communicate effectively with a patient who can't hear you whilst your mouth is covered, you know, if they're used to like lip reading, for example? So there are a few challenges that do need to be sort of addressed. But in short, our government has not instructed us to cover our masks, even after Boris Johnson, you know, was, you know, diagnosed with COVID and then very soon after recovered. I'm not so sure about that, but, you know, at no point have I seen him in public with a mask on, like, you know, the other leaders of various countries.
There was another question he asked about medicine, I think.
Yes, prophylaxis.
Yes.
So, honest answer, I don't know. I don't know. I doubt it, because if there are still at present many challenges with what we identify as quite basic PPE, and sort of you know, and managing COVID patients in terms of location within a hospital, I can't begin to think that there would be talks of providing doctors with prophylaxis. Yeah, I'm not too. This is the first time actually I've heard of potential prophylaxis of COVID.
All right. Well, thank you, Mundir. I have a question from one of our students. Then a few. Then one more kind of comment from a colleague of mine. So I'll let one of my students talk. Asil, can you hear me?
Yes, doctor. Can you hear me?
Yes, we can hear you, Asil.
Okay, I have 2 questions, doctor.
Yeah.
The first one, we have heard about many experience of using malaria vaccine. Does its use actually reduce the virus?
The malaria vaccine, did you say?
Yes.
Okay.
Does its use actually reduce the virus?
Okay. And what's the second question?
The second one, behalf of my colleague, what's the percentage of people suffering permanent damage or an organ damage after being cured?
Okay.
So people who have fully recovered, do we know if there's any permanent damage following that?
Okay.
Very good questions, Asil. Very
Really
good questions. I had my hand on my heart there, so well done.
I do have to apologize, Asil. I don't think I'll be able to offer you an answer which will be adequate, and that's because of the level as to where I am in my training. So I've currently just qualified as a doctor, and to be able to answer these questions, I would have to be we're looking at maybe 5-6 years ahead. And this is something I didn't know about. I didn't know that the malaria
vaccine. I think he was talking about hydroxychloroquine.
Oh, okay. So I did do a bit of reading on the treatment that we've provided for COVID. I'll be very honest. I took the approach to look more, subhanallah, at the virtues of black seed, which is as you may know, it's identified as prophetic medicine, and so that's what I was looking at, and I was subhanallah, the quantities of this chemical in black seed is incredibly high, and so I've been taking my black seed every morning. But in terms of medical evidence-based information as to how efficient it is, I can appreciate that if it was undoubtedly efficient, it would be out there by now. I know that there are many labs across the world working towards developing a vaccine which is cost effective and effective, of course, medically, and also has very, very little, if not no, side effects. And I don't think we're there yet. So currently what is available, I know that some patients who are at sort of the near end of the progression of the disease have been there is access to this medication, but in terms of how effective it is in treating, I'll be very honest, I don't know. Even if you were to read various papers, you would find conflicting information. So at this stage, it's incredibly important, I think, for us, within this field, to continuously read and disseminate information as we latch on to things which seem quite important. And for your second question, what percentage of organ damage is done as a result for the people who have recovered? Again, I do apologise, I don't know.
I think it's still early days as well for me to know, because it's quite a young pandemic. So to classify something as chronic damage would need years upon years.
Yes, definitely. I can share maybe an opinion. So the key thing, symptom with COVID is the dry cough. And what happens with this virus as it infects and takes host of your pulmonary cavities, of your lungs, is that it causes fibrosis within the lungs. And fibrosis, as we understand it, in the medical world, is irreversible. And so the damage that is done to the lungs would persist with my limited medical knowledge. The extent of that damage on function, however, can vary. So people who have who are long-term chronic smokers, for example, they would inevitably have some damage on the lungs which would be irreversible. And people who have had exposure to like mining or asbestos, so basically like quite harsh chemicals, and they would have irreversible damage on the lungs. And when they get sick, their symptoms would be worse. However, in their normal state, in their general health, if they have good health and they still have this, irreversible damage on the lungs, they pretty much are okay with it. And so even if there is long-term damage to a particular organ, it doesn't always impair function. So we'll need some time to identify this and to to further investigate it.
So just to comment on hydroxychloroquine, our understanding so far from some papers, especially with some comments from Professor Luke O'Neill, is that the ability of hydroxychloroquine to delay or inhibit the protease activity inside the cell, which is quite important for viral replication and RNA reverse transcriptase, is unchallenged in malaria. However, we don't know how effective that is in terms of Ebola and in terms of all these corona, not Ebola, but in terms of SARS and MERS and the new the new SARS virus. It's still under trial. On paper, it should come back with positive results, but so far it's only been a matter of assumption, and it's still under evaluation. Unfortunately, until now, nothing has come back. I have one more comment, and then we'll give you a few minutes to give us your final thoughts. Ahdab, are you there? Another immunologist colleague of mine. Ahdab? Hello?
Hi. Yes.
Yes.
Hello.
Hello. Another colleague of yours from London, Fumi. She studied in London.
Hey.
Yes. Hi. Hi, Funmi, and thanks for being here. We've enjoyed the discussion very much, and also congratulations for being a doctor as well.
Thank you.
So I do have a very quick question. So based on the current data, do you think we can, before the disease develops, can we differentiate the outcome, the patient's outcome?
So the key things that are known, so this is based on the the data that we have, and also comparative to other diseases, is regarding the patient's age and regarding the patient's pre-existing medical conditions. Now, these two seem to be like the most important factors in determining how the disease will progress. Of course, there are patients who have, who are of young age. And when we're speaking of young, we're speaking about under 65. That's what we identify as young. And for people who don't have any known and pre-existing medical conditions, have actually ended up developing quite severe cases of the disease. And of course, in some cases, some people have actually also lost their lives, unfortunately. But even with that information, it's still very limited to be able to know, to what extent a person will suffer ultimately from this infection. And the key thing is, if you imagine a pre-existing medical condition needs to be diagnosed. I know that one of the first cases of the youngest people actually to die in the UK, it was reported that whilst they became infected with the disease, I think congenital defects of their heart was identified on imaging and on scanning, which they didn't know about. And so there will be some people who might appear healthy in their lives, but it takes a disease like this to sort of bring to light impaired function of specific organs, and thus, do we still identify these people as being previously healthy, and such and such? And so at this stage, again, it is quite difficult to identify how the disease will progress in some people. But of course, there's definitely some research being done on trying to sort of risk assess a patient. And of course, in different hospitals, what they're using at the moment is the length of time that a patient has been presenting with symptoms, and also the progression of their disease, just simply based on a history, after they give a clinical history. Secondly, the patient's age, and then thirdly, their pre-existing medical conditions. And so they're using those key factors to sort of stratify patients within the ward to identify who might be at most risk. But again, this information is clinical, and it's not necessarily evidence-based, so it's quite difficult.
We have another comment by Dr. Fadi. Yes, Fadi, can you hear us?
Yes, I can hear you. Can you hear me?
Yes.
Yeah. Doctor, earlier you mentioned that based on the clinical symptoms evaluation, the patient will be sent to the COVID-19 department or COVID-19 quarantine in the hospital.
Yeah.
So, and many reports came out from China that some patients have contracted the infection after they're sending them to quarantine.
Yes.
Unfortunately. So don't you think it is we should wait till the lab result came out before we send the patient to the quarantine?
Yeah, of course. I definitely think so. I don't believe, though, that we have the facilities to do that, because once we admit a patient, if they are suspected COVID, then we have to treat them as if they have COVID. And we don't have the facilities to treat people on a different ward who are suspected COVID. Because, for example, if you had, say, for example, you had 10 patients who presented with the symptoms of COVID and they all thought that they had it and, you know, they were at risk of deteriorating. If we don't put all of those patients in one place, they have risk of infecting other people. And so even if you start testing them, where do you keep them? They have to stay on the ward. You can't send them back home. And so in most cases, when people are presenting with a symptom, they're not that debilitated, so they can get tested sort of in the test centres, which are organised outside of the hospital. So it's literally like a drive-through. They drive through, they open up their mouth, you know, they're swabbed, and then they'll get the results in a few days, and then they go home. But for the people who need medical attention and cannot return home, the only place for them really is the COVID ward. I know that some hospitals are doing things a bit differently because they have different resources, but the ideal situation, of course, would be if a person presents with symptoms, you completely isolate them from everybody in the hospital, and then effectively you have like isolation mini beds or wards, but we just don't have the capacity for that, unfortunately, or the woman power and manpower. I say woman power because our NHS is most served by women.
Most of the world is, not only the NHS.
Yeah.
Fummi, let me just remind the listeners of what you've done so far. At 16, national papers predicted you to be the first female black Muslim Prime Minister in the UK. You've given talks in TEDs, you're an author, you're a speaker, you're the founder of Race Against Medicine, an internationally operating social enterprise to empower us as well. Yeah. It's an honor to have you speaking here with us. A lot of my students and a lot of the attendees are females in their very early years who decided to do medicine, who want to find a place for themselves in this world. I'll give you the mic for 1 minute. If you want to give some words of advice to some young girls who are listening to you now, some of them who are looking up and thinking, you know what, I can probably do this.
Most definitely. Well, firstly, it's been an absolute pleasure to speak to all of you today. You know, it's quite a surreal situation, sort of reading about COVID, seeing it through the window, hearing it through my colleagues, and understanding like how devastating it is across the world. So I think to be able to just speak on it in terms of like from the information sharing standpoint, it does help with the sort of like managing everything that's going on, like personally. So thank you so much for the opportunity. You know, you've decided to embark on a career that is everything but a career. So medicine, healthcare, science, it will infiltrate into your veins, it will infiltrate into your life. And what I mean by that is, it doesn't mean that you will never have a break and you'll be working all your life and you'll never, you know, you'll never get rest, because that is not what you sign up for. But it is a responsibility that you take on and you commit to serving pretty much until you are no longer bearing the gifts that enable you to serve. And I remember when I first ever applied to study medicine, this was, oh God, how old was I? Oh my God, I was 18. So this was just about 8 years ago. And I didn't get in. It's very competitive to get into med school. And so I did chemistry as my first degree. And after I completed that degree, I absolutely adored chemistry. I still wanted to be a doctor, and I applied again. And so in total, there were a total of 7 rejections from 7 universities said, no, you can't be a doctor. And it forced me, those 3.5 years and those 7 rejections absolutely forced me to go back to the drawing board and really refine, why on earth do I want to do this? And for me, my reason actually is quite simple. You know, I want to ensure that my time on this earth is spent supporting people to be better and to do better. So that's not just by helping them clinically, or, you know, if they're at, you know, if they have poor health, for example, but also through education, through inspiration, and through providing opportunities. And when I put it like quite simply, you know, that's effectively my life mission, is to serve. That's it. I always want to be in a position of servitude. And the best advice I think I can offer, especially during these times, and to everybody listening, not just the wonderful ladies, but also the wonderful men as well, is that you need to decide why you're doing this. And I think at any point in your career, it's important to reevaluate why you're doing this and make sure that you serve that why. And if you refine it, if you change it, if that reason changes, that's fine. But just know why you're doing this. And if you're in a position of servitude and you're serving people, recognize that the gifts that you have effectively, especially in the world of medicine or in the world of scientific research, they literally put you in a position where you are between a sick person and their time to meet the Lord. You are in between that time. So all the knowledge that you learn, all the skills that you learn, all the passion that you have to serve people, all of that comes into play in that very moment. And beyond the work of, you know, working directly with patients and researching and studying and trying to ensure that all the information that we use when we're supporting people is perfect ultimately, it takes some time to get there. So before you become qualified, before you have that job that you know is going to enable you to do all the wonderful things that you want to do in the world, do something, serve. Do not wait for somebody to instruct you, to tell you that, oh yes, now you can serve. Don't wait for that graduation, for that qualification, for that job to serve. You serve with everything that you have whilst you have the time. So right now, you all have adequate, ample interest and information on COVID-19. So you have a responsibility to serve the people around you. You have a responsibility to speak to your family, speak to your communities, and ensure that people are taking the necessary steps to do their best to stay safe, but also share knowledge that is more than what the news is sharing, and do your bit to serve. So thank you so much. I hope that one day maybe I have an opportunity to meet you all.
Hopefully. Thank you very much. Thank you very much. I think I can say this is my favorite episode so far. I mean, listen, this is only me speaking, but I'm the only one who has the power of the mic. So I assume the rest here have agreed. Fumi, how can they follow you? Do you have a Twitter account? Do you have Instagram?
Let me type this up here.
If you can type it on the chat, or on the screen, yes, so they can...
So I'm on Instagram. You can find me at Funmi Abari. That's the same for Twitter as well. Is Twitter an at? Yeah, I think it is. So I don't really use Twitter, but that's the same for Twitter. And then if you want to follow my projects, the Empower Us project, and then also there's Race Against Medicine. But if you follow me on Instagram, you'll see these underneath in my bio.
So people, please type that down now. Take screenshots or whatever you want to do or you need to do, because we're wrapping this up. Okay. Fumi, one last chance. What team do you support in North London?
You know what? I support the team in London that is utilising their millions to support people who are most vulnerable during this pandemic. that's who I support. So when I find out a team is doing that, that's who I'm going to support.
Let's hope it's Arsenal, right?
It probably will be.
Thank you, Fumi, very much. Thank you all. Thank you, one and all. Thank you for all the participants, and stay safe, stay distant, and speak to you soon. Thank you. Bye-bye, everyone.